This lecture is on intrapartum complications, focusing on preterm labor and dystocia. So preterm labor is idiopathic in nature. 70 to 80% of the cases are. We don't know the cause. It makes it at-risk patients hard to identify for providers and prevention very difficult. We do know having a previous premature delivery puts you at an increased risk with subsequent births. So one previous preterm delivery, you have a 35% risk. Two previous preterm deliveries, 70% risk for subsequent pregnancies. So we also know that an incompetent cervix is a known risk factor. Other potential risk factors, uterine anomalies, such as an odd shape to your uterus or a septum in your uterus, infection, cervical UTIs, STIs, multiple gestation, polyhydramnios or hydramnios, excessive amount of amniotic fluid, placenta previa or placental abruption, tobacco, substance abuse, and age and ethnicity, being less than 18 or greater than 35 years old at time of pregnancy, and African American ethnicity. And when we're discussing preterm labor, we are defining that for the purposes of this lecture for 20 weeks to 37 weeks gestation. Preterm labor signs and symptoms. The important thing to note is that all of these signs and symptoms can be part of a normal pregnancy signs and symptoms. So we need to educate the woman that if you're feeling these and it feels like something is not right, or you need to watch for changes in these symptoms. And until proven otherwise, you need to assume it's preterm labor until proven otherwise. So uterine contractions 4 or more per hour. They can be painless, but you may notice the tightening. Menstrual-like cramps, low backache, pelvic pressure, intestinal cramps or diarrhea, increase or change in vaginal discharge, and then that feeling or intuition that something is not right. So in combination, they're more alarming than in isolation. So diagnostics. The fetal fibronectin is a cervical sample that we can collect. It is a protein that is normally found in fetal tissue. If it is present in the vaginal tissue or in the vaginal vault during 22 to 34 weeks gestation, it's a strong indicator that you will deliver in the next 2 weeks. Absence is a good predictor that you won't deliver in the next 2 weeks. It's done by vaginal swab with a speculum, and after 34 weeks, fetal fibronectin is normally found in the vagina, so the test is not predictive for late preterm delivery. So for preterm delivery after 34 weeks, it's not predictive. It's helpful between 22 to 34 weeks. Cervical length. Cervical shortening can be measured through vaginal ultrasound. The normal length is 3 to 4 centimeters, and so any shortening in that or effacing of the cervix can be objectively measured with ultrasound to determine if they're at increased risk for preterm birth. Wet prep is checking for any vaginal infection. So it's a swab of the vagina looking for any sexually transmitted infections, bacterial infections, yeast infections that could cause the signs and symptoms of preterm labor. Urinalysis to check for urinary tract infection, and then STI screening. So treatment, these are some simple measures that may or may not work, is bed rest, hydration, either oral or IV, emptying bladder frequently, trying to decrease stress, which is difficult when you're worried about a preterm birth. And we haven't really found a great way to prevent preterm labor. So these are some things that may or may not work. And then medications we'll get to in subsequent slides. And then another important thing with treatment is treating the underlying cause. So if we know with our previous diagnostics, if any of these are positive, we know that those could be an underlying cause for the preterm labor, and treating those infections can decrease or stop the preterm labor. So medications for treatment, terbutaline is not a first-line choice, but it is still used intermittently. It can be given several different routes. And the goal with this is to delay delivery 24 to 48 hours, not preventing preterm birth. And the reason we want to do that is to get the steroids on board for the fetal lung maturity, which we'll get to in a minute. So the use of this is more just to delay preterm birth, not stop it. It is a smooth muscle relaxant, so it does decrease contractions. It has epinephrine-like side effects. So the symptoms for mom are tachycardia, flushing, nausea, vomiting, heart palpitations. It can cause complications related to those symptoms, such as arrhythmias, hypotension, pulmonary edema, and extreme tachycardia that can be complicating for mom. So if the maternal heart rate is greater than 100, you need to not use this medication. And terbutaline does cross the placenta, so you will see tachycardia in the fetal heart rate on the fetal monitor. Nursing implications with this, so be thinking it's short-term use, watching the vital signs closely for mom, watching the fetal monitor closely for tachycardia in the fetus, doing a focused respiratory assessment, knowing that pulmonary edema is a risk factor, and then emotional support for mom. They don't feel well on this medication. Preterm labor is a scary diagnosis, and then giving them as much information and support as you can. Nifedipine is a calcium channel blocker. Side effects of this: hypotension, headache, tachycardia, flushing. This is usually given oral, and it can be used with terbutaline in conjunction. These can be given together, but not with magnesium sulfate, because they are both calcium blockers. So magnesium sulfate's the next medication. It's a calcium antagonist. Calcium is needed to produce prostaglandin to initiate labor. And so they originally thought giving this would decrease the patient progressing into true labor from just having contractions. It has a direct effect on the myometrium. Side effects we talked about in the preeclampsia lecture, watching for decreased blood pressure, decreased respiratory rate, decreased urine output, decreased deep tendon reflexes, change in level of consciousness, so things that are going to over-sedate the patient beyond therapeutic levels. And the interesting thing is they thought this medication would stop preterm labor, and what they found is that it didn't stop preterm labor, but it did have a neuroprotective effect on the newborn. So newborns, moms that were treated with magnesium sulfate during their pregnancy for preterm labor had better neurological outcomes post-birth. So ACOG, the American College of Obstetrics and Gynecology, supports the use of magnesium sulfate in deliveries prior to 32 weeks for the neuroprotective effect. So patients will be on that for 48 hours while they're getting their glucocorticoids, and then taken off of it, and it's a benefit to the baby. May decrease contractions, may not. We know it doesn't necessarily stop preterm labor, but it does have a neuroprotective effect. Betamethasone is the last medication, and it's more of a medical management than a treatment. It increases surfactant production in the fetus. So this is a glucocorticoid that is given as an intramuscular injection into the mom, and it crosses over into the placenta and increases surfactant production in the fetal lungs. So immature respiratory system is the #1 risk factor for premature birth because of the low surfactant levels. If betamethasone is given at least 24 hours before delivery, it will help speed maturity of the fetal lungs and have a better outcome respiratory-wise for the newborn. they get 2 doses 24 hours apart. So they get one at 10 a.m. on the 4th, and they get one at 10 a.m. on the 5th. And once those medications have been in for a full 48 hours, they're supposed to be the most therapeutic. New research has shown that this medication can be given up to 37 weeks gestation to improve lung function. So the whole gamut of preterm labor that we talked about, 20 weeks to 37 weeks, this medication can be given to the mom, and they have seen benefits for the newborn. So in summary, for preterm delivery, every day counts. You want to continue the pregnancy as long as possible, as long as it is both beneficial for mom and baby. Special considerations: delivering via vaginal route or C-section route, there's different benefits to both ways. You don't want to put a lot of increased pressure on a fetal head that is still developing or that is preterm. So sometimes that's an indication for a cesarean. Other times they will cut an episiotomy to have less pressure vaginally and do a vaginal delivery. So that's up to the providers that are involved with the delivery, but those are different options. Avoiding opioid analgesics, systemic opioid analgesics that will cross the placenta, such as fentanyl or morphine during labor, because these babies are already at an increased risk for respiratory stress or respiratory complications at birth. And so further sedating them puts them at an increased risk. So other pharmacological pain management techniques are recommended over systemic opioids. Having a NICU or a neonatal intensive care unit available, or transporting the mom to the right level of care for that premature newborn when mom is safe before delivery is optimal. Contraindications to arresting the preterm labor: fetal infection, chronic fetal distress, intrauterine growth restriction, intrauterine death, pulmonary maturity that can be measured through amniocentesis, maternal distress, and placental abruption. So this list of reasons, the risks of continuing the pregnancy outweigh the benefits of continuing the pregnancy, and so we shouldn't try to delay delivery. All right, the next topic is dystocia. So the word dystocia means stuck. It can be applied to different parts of the labor process. It's most commonly known associated with shoulder dystocia, which is depicted in this picture. The fetal head comes out, the anterior shoulder gets stuck under the symphysis pubis, and this is an obstetric emergency. But we're applying this word more generally to the entire labor process and just dystocia involved in the different components of labor. So, dysfunctional labor, why does this matter? A prolonged labor leads to maternal exhaustion, maternal dehydration, increased risk of infection for mom and baby, and potentially poor or increased morbidity and mortality for mom and baby. The etiology behind dystocia is focusing on the 5 P's of labor. We're going to see what goes wrong in each of these different P's and how we can treat it as a nurse. So the powers, just to review, the powers are the contractions. The passageway is the birth canal, the type of pelvis. The passenger is the fetus and the placenta, the size, position, health status, and gestation. The psyche is mom's stress level, childbirth knowledge base, her support system, and her trust in the healthcare providers. And then position is referring to the maternal position during labor. Whether she is moving, back-lying positions can cause dystocia. So first we'll focus on the powers. So the uterine contractions and uterine tone. Our goal with uterine contractions, or what we have found to be an ideal frequency and duration, is every 2 to 5 minutes, lasting at least a minute, but less than 2 minutes, which we'll get into that more specifically when we go over fetal monitoring. But there's an amount of pressure and frequency and duration that we have seen is optimal for ideal labor progression. We've talked about the strength a little before, but palpating the uterus is the best way for you to get familiar with the strength of the maternal contractions and how they're progressing throughout the labor. So we talked about at the peak of a contraction, when it's the most tight in the abdomen, when you palpate it, does it palpate like palpating your nose? Then it's mild. If it palpates like palpating your chin, it's considered moderate. And if it palpates like palpating your forehead, it's strong. So that's a subjective, non-invasive measurement of uterine contraction strength. You can also read your patient and their reaction to the contractions, but we know just as pain, patients' reaction to pain is very different. Their reaction to contractions can be very different, and it's not necessarily indicative of strength or how well they're progressing the labor. We can objectively measure strength of contractions internally using an intrauterine pressure catheter, which we'll get into more later, but this measures the pressure inside the uterus in millimeters of mercury. And we have found that in a 10-minute window, 150 to 300 millimeters of mercury of pressure within the uterus during that time equals adequate contractions to progress their labor. Resting tone is also an important part of the uterine contraction. The uterine muscle must have a resting time of at least 60 seconds between contractions to adequately be refilled with blood, relax, and get oxygenation back to that muscle so that it can function properly. So, problems that occur with the powers. Hypertonic labor. So this is frequent contractions that aren't necessarily very strong and not effective. So they're painful contractions that are not progressing the labor. This has also been called prodromal labor. It usually occurs in the first stage, early phase, and can be caused, correlated with the other P's as well. So problems with this is that you're having frequent contractions, you're not progressing, and it's still decreasing placental perfusion because the contractions are occurring, obstructing that flow, increasing the risk for fetal distress and maternal exhaustion. Treatment. Sterile vag exam, accurate sterile vaginal examination, assessing dilation effacement to determine if they're progressing in proportion to the contractions that they're having. So if the contractions palpate mild to me as I'm palpating her abdomen, but her cervix is progressing, they're adequate for her. If they're palpating strong and I'm checking her cervix and it's not dilating, those contractions are still not adequate for her to progress. Pain management, bed rest, sedation, such as Ambien, longer acting opioids like morphine. We know we're still in the early phase of labor. We're not progressively changing our cervix. We have time to give them longer acting medications to help them get through this period of hypertonic labor. Discontinuing medications if they are on inductive medications such as oxytocin, stopping this, allowing the mom and baby to rest, and then starting them up again to see if we can make better progress. Tocolytics are also a choice. Terbutaline, we talked about how that's a smooth muscle relaxant. It works very quickly and it wears off relatively quickly. And the goal with this in hypertonic labor is to knock out the contractions that are not effective, let the uterus relax, the baby recover, and then see if they spontaneously start up again, or we start oxytocin if those contractions are more effective at progressing the labor. The other side of the powers is hypotonic labor. So these are weak, irregular, ineffective contractions. Etiology behind that can be an overdistended uterus, an obstructive bowel, obstructive bladder. So your bowel and bladder are full, your uterus is overdistended, and it's not allowing progress down or descent into the pelvis. This often is associated with secondary inertia. So what that means is we had a well-established contraction pattern. The woman was progressing, and then she gets to 5 centimeters and she stalls out, is what nurses will say. Often this can be associated with fetal position, so that occiput posterior position. They progress, and then their head doesn't rotate in the pelvis like it should, and they get stuck. And then their contractions kind of peter out, and they're not progressing like they should. This can be related to, we talked about the overdistended uterus, bowel or bladder getting in the way, excessive analgesia. There's conflicting research about how much anesthesia or analgesia affects progress of labor. And where I think this relates with hypotonic labor is your normal muscle contractions of your body, your abdomen, your pelvis that occur with the pain of the contraction isn't necessarily occurring. Everything is more relaxed, and so that pressure that's needed to turn the fetal head and the pelvis and get them into the correct position isn't happening, and that can cause this secondary inertia hypotonic labor. They're having contractions, but they're not effective at progressing them. So treatment could be the uterus. The reason they're having ineffective contractions is the uterus is worn out. So IV fluids, giving hydration, intake and output, getting the bowel and bladder out of the way by emptying them. Augmentation, giving oxytocin to see if we can give some medication to augment those contractions and make them more effective. If they are on oxytocin, they must have continuous fetal monitoring, a continuous IV infusion, and it creates less mobility for the patient. So it's good to try to use more natural methods of getting the contractions started again before going that route. And then assessing the other P's. That's important with both hypertonic and hypotonic. What's the maternal position? What's her psyche? How is she tolerating this labor? And see if those can be part of the reason behind the ineffective contractions or the lack of progress. All right, the next P is passageway. So the main cause of that, the etiology, is cephalopelvic disproportion. So the pelvis is too narrow or the fetus is too large. My best way to describe this is square peg, round hole. They're not fitting together. If the fetus can't descend in the pelvis, then delivery via the vagina is not an option. Too many complications, increased morbidity and mortality for baby and mom. This is a subjective assessment, whether they're fitting, and sometimes we call it trial of labor. So if we feel like they're not fitting, we can continue to let them try to give them adequate contractions and time for the fetus to descend, and if they don't descend, then it's a failure to descend, indication for a cesarean section. Placenta previa is a passageway problem that the placenta is obstructing the route out of the vagina. And then bowel and bladder distension, it's an obstruction. It's something blocking the passageway, not allowing the fetus to descend in the pelvis. So treatment, pelvimetry is measuring the biparietal diameter, looking to see through palpation if you feel that the fetal head is going to fit through the pelvis. Measuring station adequately, is the baby's head engaged? Is it moving down and related to the ischial spines? Trial of labor we just talked about. Delivery route, operative vaginal delivery using forceps or vacuum is contraindicated if you're worried about the passageway. So if you are worried about cephalopelvic disproportion, using a vacuum or forceps to allow the head to come out has an increased risk of the shoulders getting stuck and more complications. There's an increased C-section rate, so that's the delivery route, increases the risk of having a C-section if things are not fitting correctly. Positioning, maternal positioning, squatting, side lying, sitting, things that open up the pelvis and optimize that diameter to allow the fetal head to fit through if it can. And then assessing the other P's. I talked about maternal position, psyche, the contractions, are they actually effective to cause fetal descent, etc. Passenger. So, passenger is placenta and fetus. The etiologies that cause dystocia: multifetal pregnancy. More than one baby in there. This can be overdistended. Malpresentation, we talked about occiput posterior position being very common cause for dystocia. Face, brow, breech presentation, so positions that are not ideal for vaginal birth. Macrosomia is that large infant, so if the baby is too big to fit through the pelvis, it's a dystocia cause. Shoulder dystocia, more common in a large for gestational age infant, so the head fits through, but they have a very wide shoulder diameter and it gets stuck under the symphysis pubis. We've talked previously about how the head is the largest diameter, but sometimes in those large for gestational age babies, the shoulder diameter is very wide and can cause problems as well with dystocia. It is an OB emergency if the shoulders get stuck and the head is out. It happens in approximately 2% of births, but it can cause brachial plexus injuries, clavicle fractures, and hypoxia for the baby if you cannot get them out in a timely manner or get the shoulder unstuck. Hydramnios, too much amniotic fluid. It can make that balloon too cushiony and the contractions are not effective. And you think, just break that, just rupture those membranes and get that water out of there. Well, there's risk with that as well. If you have hydramnios, increased risk of that cord coming out of the vagina, which is called an umbilical cord prolapse. So it just creates more risk if they have hydramnios. And then chorioamnionitis is infection of the chorion or amnion. So infection within that intrauterine environment causes the uterus not to function as well as it should and may not have the normal progress of labor. So, treatments. Position changes, another one of those P's. Making the ideal environment for the fetus to descend into the pelvis. We talked about the musculature of your abdomen and pelvis, reinforcing that position change to that occiput anterior, causing fetal descent, opening up the pelvis as much as it can to optimize that diameter. If twins, for position changes, if it's a multifetal pregnancy and both, for a twin pregnancy, if they're both vertex-vertex, there's potential for a vaginal birth. Breech, we can try different position changes called aversion or some other natural methods that are out there. Acupuncture, acupressure, moxibustion are different natural methods that can be used to try to turn a breech fetus to a vertex position. It's not always successful. Delivery interventions, we talked about operative vaginal delivery not being ideal when you're worried about malposition, or you're worried about macrosomia. So with big babies, if that's the cause of the etiology with passenger, you need to worry about using operative vaginal deliveries. Fetal monitoring, watching closely for fetal distress. They give you clues as to whether they're tolerating the labor or not, and that's something you as the nurse are responsible for assessing and responding to appropriately. Increased C-section risk because sometimes it just doesn't fit or you cannot fix this etiology. And then early detection. It's ideal to figure out that the baby is not going to fit through the pelvis or that they're breached before you get to the pushing phase. Increases morbidity and mortality if you are trying to fix the passenger problem emergently. And the last P is psyche. So maternal exhaustion, advanced maternal age, nulliparity, overweight, caffeine intake, hormone regulation. These are all identified as causes of dystocia. So the hormone regulation is the release of stress hormones. If the mom is not coping well with her labor, they can act on the smooth muscle of the uterus and decreases uterine contractility. which is not therapeutic for labor progress. Uteroplacental perfusion, not getting enough oxygen, not breathing in an effective manner, increasing your stress and tension can decrease perfusion to the placenta, which increases stress for the baby and decreases your labor progress. Support. The presence, the absence of support, or the mom not feeling supported during labor increases these hormones, decreases uteroplacental perfusion. There's a lot of research to support presence of continuous labor and how that decreases the risk of assisted delivery or apparative vaginal delivery and delivery complications. Treatment for psyche, continuous labor support, whether it's the partner, the nurse, the doula, the friend, someone that is trusted and is there at all times with the mom. That is very important. Controlling the environment, dimming lighting, music, minimal interruption, calm, supportive communication, equipment that can make the patient more comfortable, a ball, hot, cold packs, water, position changes. One of the best things that helps with that is distraction from your psyche, right? If you're focusing on doing different positions or controlled breathing, goal-directed behaviors, it's harder to think about your stress. Pain management. Following their pain management plan can reduce their anxiety and stress. And then education. Promoting childbirth education before you get into labor, providing education during the birth process, and giving them choices whenever possible empowers that woman to feel like they have more control and decreases their anxiety and stress.